I'm Patrick Muck, and welcome to Sharing Cross 2026. I'm super excited today. I get to sit with some real icons in the not only PE space, but in the whole VTE space. I'm with John and Rob today, and we're going to kind of discuss the PE therapies. We're going to discuss research, and we're also going to discuss the future. So I appreciate you guys coming today. I think this will be a lot of fun. And so we're going to kick it off with, you know, both of you were the national PIs of some incredible trials. And so we're going to start with you, John. I was hoping you could kind of summarize for us the results of the STRIKE trial.
Well, thanks a lot, Pab. It's great to be here with you. And STRIKE is a large endeavor, been ongoing for quite a few years now. There are prospectively 1,250 patients from all around the world with intermediate and high-risk PE who have had a endovascular thrombectomy using computer-assisted vacuum thrombectomy. And all of these patients have been enrolled in a one-year follow-up registry, which is a big endeavor because this is the first time we're getting not just the acute safety efficacy things that drive a lot of our practice, but we're also getting the long-term data on how our patients are doing after these procedures that I think are increasingly going to change things like guidelines and how we're approaching things into the future. So STRIKE is ongoing, but we are beginning to see some important data out of it. And here at Charing Cross, we presented data for 1 year evaluation with the newest type of thrombectomy, which is the 16 French system. And I'll cut to the chase and say it was all extremely positive when it came to quality of life as well as patient-reported outcomes.
Nice. Yeah, nice synopsis. You know, I think between the three of us, we probably have well over 30 years of experience in endovascular therapies for PE, if not maybe we're approaching 40. So it's kind of crazy. And for the longest time, we didn't really have the best results. And now you're, you know, leading such an important trial. And then Rob has the, you know, first randomized controlled trial for endovascular therapy versus anticoagulation in the STORM trial from Penumbra. So Rob, can you please share with us your thoughts and the highlights of this trial?
Thanks, Pat. So you're absolutely right. We had not seen an endovascular randomized trial comparing endovascular therapy to medical therapy in 12 years. And so we were really thrilled to get this trial off the ground and finish it successfully. Specifically, there's obviously been a tremendous amount of enthusiasm for the potential role of mechanical thrombectomy. But again, we had no randomized data comparing thrombectomy to anticoagulation alone. So to summarize the findings of the trial, we randomized 100 patients. The primary outcome was stabilization of right heart function as adjudicated by a change in the RV to LV ratio on a set of paired CAT scans. One CAT scan would be at baseline and one CAT scan would be at 48 hours. And the change in the RV to LV ratio was assessed by an independent blinded core lab. So about half the patients were randomized to endovascular therapy and anticoagulation. The other half received anticoagulation alone. At baseline, the cohorts were very well matched. So we really designed it to detect a signal in the introduction of endovascular therapy. We saw multiple findings, and this really, I think, accelerates the opportunities for endovascular therapy to take a more dominant role in the management of intermediate high-risk pulmonary embolism. First and foremost, there was a more rapid and uniform stabilization of right heart function. This was an imaging finding, but it actually also occurred simultaneously with stabilization of the patient's vital signs. A significant reduction in the clot burden as assessed on the CAT scan, a reduction in the patient's heart rate, a reduction in the need for supplemental oxygen, and a reduction in the NEWS2 score. So we really saw stabilization of the patient going along with the imaging findings suggesting stabilization of right heart function. Most recently, we've presented the 90-day functional outcomes. And this is even more powerful data. So again, compared to anticoagulation alone, the introduction of endovascular therapy, specifically in this case, computer-assisted vacuum thrombectomy, demonstrated that a statistically significant more percentage of patients had no functional limitations at 90-day follow-up. The patients return to their baseline functional status across a different metric, specifically the post-VTE functional score. And lastly, and probably most powerfully, the patients randomized to endovascular therapy were able to walk farther on their 6-minute walk distance. And when we looked at this cohort based on historic epidemiologic data, based on the patient's age, their gender, and their body surface area, 94% of the patients met their expected 6-minute walk distance at 90-day follow-up in the endovascular arm. Again, strongly supporting that early reperfusion, early right heart stabilization imparts a functional benefit for these patients. And alternatively, in the anticoagulation arm, only 75% of patients were able to meet their expected walk distance. So we're seeing a tremendous benefit here. We're seeing early stabilization of right heart function. We're seeing hemodynamic stabilization of the patients. And it appears to be that translates into broad functional benefits for the patients as early as 3 months after randomization.
Yeah, it's amazing. That's a great synopsis. And for the first RCT in this space, congratulations. And really, the work that both of you all have done, you're not only helping your hundreds or thousands of patients locally, but tens of thousands throughout the world year by year. That's only going to get exponentially higher and higher. So congratulations. What you guys are doing is truly changing care for patients, moving the needle, and just helping thousands and thousands of patients. So, looking forward, okay, we've got one last question for each of you. Say we get the band back together. It's 2031. 5 years from now, we're at Charing Cross. What do you see the future looking like? What does the future of this space hold? Is it more data to support what we're doing? Do you see combining therapies? Are you going to do cave-in with some thrombolytics, building upon the high pytho data to perhaps treat the more distal, smaller branches in the PAs, less ICU care? John, what do you see if you had to pick one thing in 5 years you think will be different?
Yeah, I think it's a great question, because I think we've, over the last 5 years, seen a huge explosion in interest in this exact space. So if I was to say, what are we talking about in 2031? I think two things really come to mind. The first is guidelines. We're going to see new guidelines from Europe, from the US and abroad, where we're going to see broad adoption of, I think, the techniques that are beneficial to patients, that are still somewhat localized to higher volume places. I think they're going to go mainstream. And then the second thing I think is what's happened with other diseases, whether it's aortic aneurysms or STEMI or stroke, is there have been iterative improvements to how we've done procedures, with either the way we approach the procedures or the devices we use. And I think we're going to continue to see that with PE, where we're going to see improved devices, but as well guidance as to how to use them in the best way, how to put them correctly into the safest positions, use them at the right time, and then stop or change to something else. And I think that's what we'll be talking about at that time, more bespoke treatment for the patients in front of us.
Interesting. Rob, you're a visionary. What do you see? It's 2031. We get the pleasure of hanging out here again. What do you think?
So I'm looking forward to 2031. So first and foremost, I agree with my colleague, John. I think we're going to see guidelines emerge that recommend for specific demographics within the acute PE spectrum that endovascular therapy clearly has a role, and specifically within that, mechanical thrombectomy has a role. I think we're going to see the completion of what I'll call the first round of randomized controlled trials for the space. And we're going to start to be in the middle of enrolling the second wave of randomized controlled trials. And I think the opportunities here are really limitless. First and foremost, I think we need to re-engage with the concept of comparative effectiveness data. And so can we pit one specific device or one technique against another, mostly looking at safety, trying to really discern which patients are most vulnerable and which patients have the greatest opportunity to derive benefit. And then Pat, you already touched upon this. We're clearly seeing benefit from mechanical thrombectomy after the results of STORM and STRIKE are consistently demonstrating efficacy and safety. But we're also so pleasantly surprised about the positive results regarding HI-PEITHO. And I think this opens up the opportunity to talk about combination therapy to trying to identify the patients that would benefit from a proximal aspiration, maybe down to the lobar level, while simultaneously infusing probably very low dose fibrinolytic agents directly into the affected circulation to relieve the microvascular circulation, improve perfusion, and what benefit that can derive. I personally think that's going to be an area ripe for research. I'm looking forward to talking in the near future about those trials. And I do believe that those technologies will be synergistic. I think it's beholding to all of us to try and define what the outcomes that we want to see, not just anatomic and physiologic, but really functional outcomes, probably out to a minimum of 6-month follow-up. And then again, most importantly, to make sure that these therapeutic options are safe for the broadest segment of the population.
Well, guys, thanks so much for hanging out with us. And the work you all are doing is incredible. So thanks so much and have a wonderful meeting.
Thank you so much.
You too.